All right. Well, I want to thank everyone for coming to another trauma conference. I'm really happy today that we have Kayla Whitaker, who's our trauma and acute care surgery program manager here at WashU, to talk about a trauma resuscitation nurse team. I really think this, shows how trauma is a real multidisciplinary area, and I'm very happy that we can hear the nursing perspective on this. So with that, Kayla, the board is yours. So
Well,
thank you very
thank
much
you.
for coming.
Thank you. So I'm going to be talking about the keys to building a trauma resuscitation nurse team. And I actually gave this presentation at the Society of Trauma Nurses this year, and I changed a little bit about this to make it more applicable to our facility, but that's what we're going to go over. If I can get the slides to turn. I have no disclosures. So first, we're going to talk just for a second about my nursing journey and kind of how I got to where I am today, just because it's applicable when you see different ways that trauma resuscitation teams are built at different centers. So I started my nursing journey at Vanderbilt University Medical Center in Nashville, Tennessee, and I was a bedside nurse in the ED there for 7 years. I then transitioned into a CSL role, which is a clinical staff leader. And what that role was responsible for was we alternated and worked as a charge nurse in the ED and as an assistant nurse manager. I very shortly decided that middle management was not for me. And after doing that for about a year, I transitioned to Erlanger Health System, where I was a trauma resuscitation nurse or red shirt at that facility. And we'll talk about that program later on in the presentation. I then became the interim PI coordinator for a couple months, trying to help out there, and then stepped into the role of trauma program director. I then left and pursued building a level 2 from the ground up at Ascension St. Thomas Rutherford, and I was the trauma program director there. And I have been at Barnes for, I guess, the past 9 months. I've been here since January as the trauma and acute care surgery program manager. So when we talk about nursing models, the traditional trauma nursing care basically goes like this. Patient comes in via EMS, they come into the ED, they go to either the OR or to IR, to the ICU, to the floor. And at each of those different kind of transition points, we hand off the data and interventions that we have completed. And it's estimated that about a 30% of medical malpractice claims discuss or incorporate communication errors. And so in 2006, the Joint Commission actually established a national patient safety goal around handoffs, trying to improve them. And in 2010, the Joint Commission made this a standard. And the standard basically said that you had to have a process to provide an opportunity for discussion during handoffs. So going back to starting at Vanderbilt, you can see this is the trauma bay that I grew up in. On the right side of the screen, they had incredible standardization, very defined roles for who did what during the recess, the location for which you stand, even was printed on the floor, which you can see in the pictures. They called out their assessment in the exact same order, the exact same way every single time, which matched their nursing flow sheet. So it was really easy to get good documentation in those areas. They did readback in the trauma bay, which basically means that the trauma team leader, typically the trauma surgeon, would call out, whatever drugs we were going to give. So 100 micrograms of fentanyl. The primary nurse would say, confirming 100 micrograms of fentanyl. And then after administering the drug would say, administered 100 micrograms of fentanyl. And so very good communication. Even the equipment locations were 100% standard in every single trauma bay. So regardless of which room you went into, your equipment was within, a hand's reach of you, and you knew exactly where it was. I felt like we provided great care there. The handoffs were very well communicated. We would go bring level 1s to the OR, and I felt like it was decently quiet and people would listen. But as always, handoffs, especially when your patients are potentially dying, can be hectic. And there are always lots of people in the room, as is typical with a large academic institution. After stepping into the A&M role for a year and deciding that wasn't for me, I decided to take a leap of faith. So I heard about a program in Chattanooga, Tennessee, which was about an hour and 45 minutes from my house, in which you had trauma resus nurses who followed the patient throughout the continuum, of care. And I was really interested in this. And so I applied and started working in Chattanooga as a redshirt. So how the program here was set up was that there was a group of 12 nurses that were specially trained, and we would flip-flop different days. So first day we were red, the second day we were gray, but it was the same group of people no matter what. So when we were on red and acting as a red shirt, we were on for trauma. We were the primary nurse in all the level 1s and 2s. We would follow the patient to the OR to IR. We would round with the team. When we were on for gray, we did all the rapid responses and codes for the house. We were also allowed to do several advanced procedures, which is one of the reasons nurses really enjoyed this role. So we could intubate, place arterial lines, central line changeover wire, chest tube placement, chest tube pulls, EJs, IOs, and FlexX. We also did MTP for all patients within the hospital, which we'll talk about later. But that was something that nurses actually really enjoyed. But again, small group of people. The handoffs that I had come to know at Vanderbilt, where we handed off the patient from the ED to the OR to IR, were very different. I noticed a much larger continuity of care here because as the resus nurse, we stayed with the patient all the way until their final destination and helped to get them settled. We weren't rushed for time for running back to the ED, basically. And so as I got more ingrained into this culture, I really liked the way that this setup worked. And so I wanted to learn more about how did other facilities do this? Were other facilities more like Vanderbilt, more like Erlanger, or was there some other way that this could be done? So I started looking and found a lot of interest and a lot of discussion about places wanting to create roles like this or having roles like this, but there wasn't a lot of research. So we're going to talk about the evidence-based practice articles that actually do exist on this topic, and there aren't many. The first one is out of Nationwide Children's in Columbus, Ohio, and they developed a TNL, as they call it, or trauma nurse leader role out of a PI need that they found in 2006. And their goal of creating this program was to improve their frequent trauma bay issues, including communication, fluid management, overcrowding, documentation issues, specifically around temperatures, and pain control. How their process worked was that you would apply, you would be accepted into a 1-year fellowship. They had to have completed TNCC or the Trauma Nursing Core course before they applied. They participated in trauma simulations and monthly education meetings. And to apply, they had to have a minimum of 2 years of trauma nursing experience. Their program was set up that they had 24/7 coverage, but they were ED nurses that worked in the ED that just did not have an ED nursing assignment. They were responsible for the documentation in the level 1s and 2s. They actually led the resus from a nursing perspective from the foot of the bed. They delegated nursing tasks to other nurses in the room, and they were responsible for delivering the patient to the inpatient unit. The outcomes of their study was they found that there was an increase in nursing retention because they had created a pathway for nurses, and that patient satisfaction increased. The next evidence-based article we're going to talk about is out of Grand Strand Medical Center in Myrtle Beach, South Carolina. They developed a TNL, as they call it, also Trauma Nurse Leader program in 2015. And again, it was found from a PIPS identified opportunity. So the goals of their study when they started was to decrease the hospital and ICU length of stay and to decrease the time from arrival in the ED to final disposition to the floor or ICU. They also wanted to decrease their time from arrival to activation of MTP and arrival to anticoagulation reversal. The education that these nurses were required to have was TNCC, ATCN, which is Advanced Trauma Care for Nurses. And if you're not familiar, that is the nursing part of the ATLS course, ACLS, PALS, and ENPC. They had 2 trauma nurse leaders on within the hospital per shift, but different than the last evidence-based practice article, these nurses reported to the trauma service at the facility. They were primary in the trauma bay. They would follow the patient, and they would communicate with the other areas. They were also responsible for some process improvement reporting, process improvement projects, research, and outreach. The outcomes of their study was that they found that they had a decrease in hospital and ICU length of stay, despite a greater number of patients admitted to the ICU during the period they were studying. They also found a decreased time to TXA administration, decreased time to MTP initiation, decreased time of arrival to ICU disposition, And with that, also found that they had improved metrics around family perception of care, patient experience, and physician satisfaction. The last evidence-based, I can't talk, sorry. The last evidence-based practice article that we're going to talk about is out of Erlanger Health System, which is, as you realize, the place that I worked prior to coming here. Well, two hospitals prior to coming here. This program is the oldest program that I could find any evidence of, was developed in 2002, and the goal was to provide advanced trauma specific care to injured patients within the hospital. The program went so well, and they were so happy with the outcomes and what they saw going on with the patients, that they added rapid response to that team's scope of work in 2006. The Red Shirt program at Erlanger does report to trauma services, and they started doing MTP in the OR just on trauma patients in 2015, but actually started doing this house-wide on all patients, regardless of the location, in 2017. Their responsibilities included patient care, so they were primary on the level 1s and 2s. They would support the ED in level 3s and consults. They were responsible for assisting with PI and education, to include ATLS, ATCN, and TNCC. They assisted with outreach, injury prevention, and research. So essentially all of the pieces of the trauma program this position helped with. But the evidence-based practice article that was published in AM Surgeon on this was actually about the institutional research of using nurses to give MTP across the hospital. And the results of that research showed that the red shirts stayed closer to the 1-to-1 ratio, almost 10% more of the time than their anesthesia counterparts, decreased mean operative crystalloid by almost 3 liters, and that there was a trend toward decreased mortality by having the red shirts run massive transfusion. So I took another leap of faith and learned a lot in the process. So after 3 years as the trauma program director at Erlanger, including 4 site visits in 16 months, COVID hit. And 2020 was an interesting year for everybody. And unfortunately, all of the salaried staff was furloughed to part-time. And so I have 2 small children and I needed job security. So I decided that it was time for me to find a new position. So I was recruited to build a level 2 from the ground up in Murfreesboro, Tennessee, which is just south of Nashville. You can see the map below. And that's closer to my family. I have family in Nashville. So I went to Murfreesboro to build a level 2 from the ground up. And when I got there, what I found was that it was a community hospital. There was very little existing trauma knowledge at all. Most of the nurses had never touched a trauma patient, seen a trauma patient, taken care of one. Some of the ED nurses had, taken care of trauma patients that had presented at the facility, but were very quickly transferred out. They had no processes for incoming EMS patients. So EMS would call into the radio and they would give a report, but oftentimes there was no one actually at the radio listening to the report. So they would have patients that were CPR in progress coming in without anyone even knowing they were coming. And they also didn't have a process for MTP. They had a protocol for it and they knew what actually went in each cycle, but they had not had success in the past running MTP. And the physicians, especially in the ED, often reported that getting blood was almost impossible. So they would transfer trauma patients out without them getting it. And so what I suggested was that we create a trauma resus nurse role to basically educate across the bedside in all of the areas that touch trauma patients. So we started that program, which we called the TRN, or trauma resus nurse, with 6 resuscitation nurses for 24/7 coverage, single coverage, 24 hours a day, 7 days a week. All of them were external hires. All of them had trauma experience, and then a combination of ED, ICU, peds, and adult, critical care transport, and EMS experience. They had a lengthy orientation in which they oriented to the ED, ICU with the charge nurses on all of the areas that we touched, in the floor, with the house supervisor, with local EMS, in IR, and in the OR. And the primary functions of this role was to be the primary nurse in level 1s and 2s, assist with level 3s and consults, and to complete education across the bedside. So they would round on the patients, they would check chest tubes with the nurses and try to talk to them about what the different, modalities of care are, what the plan of care was, and really explain it to them as far as nursing care. They also participated in helping with formal education. So ATCN, TNCC, ATLS, and then FCCS, if you're not familiar with the course, is Fundamentals of Critical Care Support by SCCM. And we helped start that there too, just to try to improve the nursing understanding of critical care and the support that they were giving. They also helped and ran MTP, but specifically on the trauma patients. But what we found was that they had good success with being able to get the blood and to understand what needed to happen. And so that other departments that were ordering MTP on patients were calling them and asking them to help. So they did a lot of OB MTPs during our time there as well. They were also responsible for all of the equipment checkoffs to ensure that we weren't missing much needed items when it came time to resus patients in the ED. So we created very strict trauma bay organization checkoff sheets that went along with that. They completed orientation for all other disciplines, helped with outreach, created all the flow sheets and EMR documentation builds, and the education startup, like we talked about on the last slide a little bit. And then also just of note, this was in the presentation before, but I felt like this was important to bring up here. If you look at the picture in the top left-hand corner, you can see us standing in front of two devices. Those are eBridge and CarePoint. We actually created alerts for everything throughout the hospital. So we started with just doing trauma alerts and setting up a communication center to have EMS call into the radio and have somebody actually respond to the radio and page out trauma alerts. It was actually so successful that they rolled it out for all of their stroke alerts and all other in-hospital STEMI alerts and all other in-hospital and incoming emergency alerts. But the eBridge and CarePoint consoles that are in the picture that we utilize is actually what East Central EMS is trying to get St. Louis County as a whole, all of the hospitals within, to start utilizing to standardize EMS and emergency communications across our county. So just kind of neat. So trauma program oversight. I think a lot of people don't understand what trauma programs are actually responsible for. And so I put the slide in here. Trauma programs are actually responsible for anything that touches a traumatically injured patient. So we are responsible for injury prevention all the way through post-acute, including EMS, everything that happens during the patient's hospital stay. And that even goes so far as support departments. So if we're having problems with lab or EBS or security, we're actually responsible for the process improvement around all of that. So here's another slide that just kind of breaks down what all the responsibilities are. And so you see the trauma program in the center. We're responsible for education. We're responsible for the trauma registry, which I'm going to explain on the next slide because it's important to why we do and how we do what we do. We are responsible for outreach, injury prevention, clinical care, process improvement, advocacy, and research. So a little bit about the trauma registry. The trauma registry is created to basically provide an area of collection, storage, and a way to report all of the trauma patients that we see. And so we track all traumatically injured trauma patients in the registry. We abstract details from the EMR, so directly from Epic in our case, for over 300 individual data elements. And then we use those elements to benchmark ourselves against other trauma centers. We submit that data to the state, to the American College of Surgeons, to the National Trauma Data Bank, and to TQIP, which is the Trauma Quality Improvement Program. This data is then used for research and to improve trauma care. Specifically, that's what TQIP reports are used for, to look at what the instances of certain complications, mortality, morbidity across the nation. And it's also used for injury prevention and used for advocacy and public policy changes. So that's important as we go into nurse team structure. So how can you set up a nurse team structure, or how might you want to do it? Really depends on your facility, but you have three options basically to start with. Do you want them to focus on the ED and belong to the ED? Do you want them to focus in the ICU and belong to the ICU versus the trauma program? The American College of Surgeons in the Orange Book, actually, which came out in 2014, said the registry staff, the injury prevention coordinator, and the trauma nurse clinicians should all be supervised by the TPM, or trauma program manager. You have the options of where they function. Do they float within all areas of the hospital that touches the trauma patient? Do they float within specific units? The ED, like the first evidence-based practice article, or the ICU? The responsibilities of trauma nurses within a resus team vary widely, and it really depends on, do they float to other areas, IR, OR, do they do MTP, or do they focus solely in the ED or ICU? So if you were trying to create this structure, how would you structure? So the first thing you really have to look at, and all of these you will notice are broken down by the elements that the trauma program is responsible for. The first being patient care. So are they the primary nurse of the recess, or are they scribing, or are they the nursing team lead? A lot of places that I've talked to about programs like this will say, well, do you think that, do you prescribe to the fact that just trauma should recess trauma patients in the ED, or should the ED just recess trauma patients in the ED, or should it be a joint effort? And this seems to be something that comes up everywhere because every hospital does it slightly differently. The two programs I started, or the program that I didn't start that I was involved in, I guess we'll start at Erlanger. The trauma nurses recessed the patient. ED nurse scribed, but the ED nurses weren't actually doing hands-on patient care. It was just the trauma recess nurse. The program I started, I actually did a combined model where the trauma recess nurse was the primary nurse. The secondary nurse spot was filled by an ED nurse. The scribe spot was filled by an ED nurse, because I truly think that for these patients to get the best care, we have to do kind of a combined effort. And so that's how I set it up, but it can be done differently in different places. You also have to think about, for patient care, are they going to be running MTP in the OR, IR? And that looks different probably based off your setup. How many anesthesiologists do you have? Do you have anesthesia residency? If you do, is there room for that to occur or not? Or is that the best utilization of their time? Do they go on rounds? Do they check off your OR carts or your trauma bay carts? Just different pieces of patient care that can be set up
fit, but it's just going to be tight with having the candle
completely differently. They participate in education. So this can be formal or non-formal. Formal education being your ATLS, ATCN, TNCC, FCCS, ENPC, PALS, all of the things we talked about before. And non-formal being that more across the bedside, teaching nurses, especially as nursing turnover is really high, that becomes really important. They can assist with skills fairs, onboarding. They can help plan trauma conferences or speak at trauma conferences. And then we move into the registry, which is why I gave you kind of the overview of what a trauma registry does. So the registry is responsible, obviously, for the patient tracking, but these nurses can actually be involved in the registry. When I worked at Erlanger, we did the first few registry tabs. And this helps with a lot of things, even some things that you may not think it would initially. So it actually helps improve documentation. There is a lot of documentation that goes into the registry, but if it's not documented, they can't put it into the registry. So if you have people that are very aware of the requirements of the registry and of clinical care, you tend to get more of those required data elements documented. It also helps with concurrency. So we are required to have 80% of our charts within the registry closed within 60 days of discharge. And so if you have someone who's putting in the first several tabs of your registry, it can help to maintain your concurrency. They can additionally put in transfer paperwork or EMS paperwork, and then they can help with research. This can include data abstraction, protocol orders, labs, patient testing, follow-up, even research design. If you have a portion of your research that is heavily based on what nursing is doing or not doing, it can be really helpful to have a nurse who's experienced in multiple areas of the hospital helping you design that project. PI is the next thing that's integral to trauma programs. And so they can be involved in PI meetings, M&M, PIPs, systems, weekly PI. We found that very helpful when we were involved in different, like in our weekly PI meetings, or M&M as we call it here, because what you find is that you get a different perspective for the care that's being given. If you only have physicians who are present in those areas at that meeting, they of course are going to recognize the errors or the issues from a physician standpoint, but having that nursing standpoint is equally as important to actually improve a lot of the issues that you're seeing. They can help with audit filter identification. So making sure that your PI coordinator has the information of who has a VAP, who has a CAUTI, kind of what's going on within your patient population. They can then be responsible for the education from those PI events. So if we find that, the floor for example, didn't understand spinal precautions and the patient had a worse outcome, we can then say our PI, our plan is to fix that via education, and these nurses can be an integral part in helping with that education. They can also be involved in hospital-wide committees. Donor committee, MTP committee, code committee, rapid committee, and critical care committee are all examples that I've seen elsewhere. They can assist with outreach, so letters to outside hospitals, letters to EMS, both of which are required by the ACS, lectures at schools to talk about nursing or trauma nursing specifically. They can help with injury prevention, so teaching community stop the bleed courses. We go into high schools and do crash and seatbelt awareness courses, and they can help with that. And then just different departmental support. A lot of people don't know what goes into actually ACS verification, but there are a ton of pieces to that. So we do a lot of tracking of certifications, schedules, maintenance of certification for physicians, and they can assist with all of that. They can also help in clinic or with different survey readiness pieces. One of the main things that I tell people if they're trying to structure a program like this is look at what needs your hospital has, what things aren't working well, and if there was a person here 24/7 who could help with them, could be made better. Also look for areas of duplicability, things that need additional help. So do you need help with STEMIs or stroke or MTP, rapid response, communications? I've even seen some places lately have a helipad transport team because they've seen people with dislodged ET tubes just coming down in the elevator. It takes a while. If they have a helipad transport team, they can help with that. Same thing with a field amputation team. Some places have a team that can go out with a surgeon and a nurse to actually remove patients from vehicles if they need a field amputation. And the staff in some of these hospitals do that. So how can they support with the ACS and state designation platforms? We have a wide alcohol screening requirement to screen every patient for alcohol use and abuse if they have been traumatically injured, and that's called SBIRT. And so they can assist with that. I've seen places that have them assisting with PTSD screening. That's one of our new requirements. And then one of the things that I actually experienced firsthand, so we have to complete something called a PRQ. It's the pre-review questionnaire before the ACS site visit. If you've ever sat through an ACS site visit dinner, the questions on that are all based off of this document. It's about 160 pages and we have to fill it out prior to them coming. But in one of the sections, you have to give your average years of experience for all of your ED nurses, all of your ICU nurses, and all of your OR nurses. And then also what percentage of those people in those areas have had different types of education, like TNCC or ATCN. I filled out a PRQ one year in which my ED nurses had an average of 1 year of experience. And the reviewers actually allowed me to incorporate my resus nurses' years of experience into that, which brought the number up significantly. And I was told by a reviewer that we would have had a deficiency if we weren't able to do that. So it can be super helpful in just the nursing knowledge and depth area. They can also help with survey prep with chart review. You can see all the charts stacked out on the desk. This is back before we had virtual reviews, but you have to pull about 100 charts and you have to sift through all the trauma patients you see to pick which best 100 charts to present. So they can help with that. The new ACS 2022 standard, actually standard 8.2, requires that every nurse that touches a trauma patient must have initial trauma education and onboarding and must have yearly trauma specific education ongoing. And so that's one of the ways that I could see a trauma resus nurse team being incredibly helpful as well. Another way that I've seen these nurses utilized or have been a part of is that in 2016, we had a large scale bus crash called the Woodmore bus crash, if you're familiar with it. We had 37 children who were traumatically injured, ages 5 through 9 in that crash, several of which were very injured actually. And so they called in our trauma resus nurse team and we were able to give one-on-one care to those patients as they went throughout their stay, which was really helpful. Same thing with COVID. We pulled our resus nurses to act as a rapid intubation team when COVID first started at Erlanger. And then later when I was at St. Thomas Rutherford, we pulled the trauma resus nurses to hold ICU patients with a COVID surge because we had run out of patients we had. And then just for disaster planning for the future, if you could have a nurse that was very skilled in trauma that could be assigned patients or locations or roles within disaster planning, it would be beneficial. So we'll skim over this real quick, but this is a description of the daily work processes. And it basically just depends on how you're set up. It depends on how you want to do handoff, is that you do it as a big team, your APPs, your residents, your physicians, your recess nurses, or if they just do it between nurses, recess nurse to recess nurse. And either of those is okay. And I've seen it actually done both ways. They can round on the bays, do your equipment checkoffs at the start of their shift, or do drug cart checkoffs if you have drug carts. Then they start doing patient care, and they're responsible for patient care the majority of their shift. If they have any downtime, they can work on those ad hoc projects such as PI or outreach or anything like that. And I recommend always making a standard workflow process. So what does the application and interview process look like? This, again, completely depends on your setup. So if you are focusing on these nurses just being in the ICU or just being in the ED, you would obviously want your interview process to be heavy on those locations. In the past, what I've used for applicant qualifications is that you must have 3 to 5 years of nursing experience, at least 2 of which are in the ED or ICU. I've always preferred both. I think that especially if you have recess nurses that follow patients throughout the continuum, nurses that have both ED and ICU experience are very, very helpful in experiences like that. Pre-hospital experience is always a plus. It is very helpful and helps us communicate and navigate interactions with EMS. And then if they have certifications, a lot of these positions nationally do require an advanced certification of some sort. So CEN, TCRN, CCRN, anything like that. So those are always helpful. Then in the interview process, looks different in every institution. Things I've done in the past, I've done a pre-test. I've done interviews with situational questions that are applicable to the position. I've done skill checkoffs, and then even education on a trauma topic. So if we're going to use them to teach TNCC or ATCN or coordinate ATLS, it's helpful that we know that they can educate people. And then I always recommend a shadow, because jobs like this aren't for everybody. It's definitely not a job that you'll be sitting down very often. So what does the credentialing look like? This is probably the question I get most from other people when people reach out to get assistance on how to set up a team is, well, do you just have a bunch of APPs that work for you? And this is actually not an APP position. So you don't have to be an NP or a CNS or anything like that to do this job. But you do need to review your Nurse Practice Act. So the advanced procedures that we were allowed to do at Erlanger aren't necessarily allowed in every state. So in Tennessee, these nurses do work under the license of their trauma surgeon, specifically whatever medical director was assigned to that group. But different states allow different things. And so you have to work within your state and what procedures are allowed in that state. As far as credentialing, you want to make yearly credentialing applicable to the position. And so everywhere I've been, we've always done yearly ICU and ED credentialing. We were required to participate in SIM training, and then we did advanced credentialing for our special procedures. And so we did these checkoffs on cadavers at our yearly cadaver lab or on live patients, just kind of depended on what procedure it was. Art lines, for example, we did art lines multiple times a day, every day. So we would just get a regular checkoff by one of the surgeons while we were placing an A line. We were also required to maintain ATCN, TNCC, BLS, ACLS, PALS, ABLS, and FCCS. Again, completely depends on how the position's being utilized at your facility. ABLS is a good example. A lot of places that aren't burn centers that have recess teams require those nurses to have ABLS, because you really need to have that basic burn life support skill to make sure that we transfer those patients appropriately and take care of them appropriately while they're here. And then most places do require an advanced cert within 1 year of hire. So FTE numbers, this depends on the roles, responsibilities, and length of stay of your hospital. So a lot of people want to know, do you need 2 nurses per shift or 1 nurse per shift, or what does this look like? And it's very, very volume dependent. So at St. Thomas Rutherford, at the level 2 we were building, we had 1 recess nurse per shift for 24/7 coverage, and they covered approximately 2,200 cases per year. At Erlanger, we had 2 recess nurses per shift and an additional mid-shifter as available for 24/7 coverage. And we covered about 5,500 trauma cases per year. So that was really only half our job. But I do recommend, if you're going to start a program like this, that you do it 24/7 for standardization, because it's really hard for nurses in other areas of the hospital, specifically the floor ICU, to call for you to come help them if they're not always available or not always there. So the TRN numbers, unfortunately, I don't have any year-end data to share with you based off of this program. In November of 2022, the hospital determined, after doing a large remodel and completely changing the way the hospital processes work and setting up a program, that they were no longer pursuing trauma services. So my staff and everyone was let go in November of 22. So I don't have any final numbers. The program was very busy and it was evolving. The 5th largest county in the state of Tennessee without continuous access to trauma services, and the #1 grade county in the nation. They needed at least 2 FTEs per 24/7 coverage, but like I said, we weren't there yet, so I can't speak to the final numbers. But I can give you final numbers for the red shirts at Erlanger. So in 2019, the red shirts did 4,623 trauma activations on adult patients, all levels. After the bus crash in Chattanooga in 2016, it was determined that the peds population needed a resus nurse from the adult side, from the red shirt group, to come to help with all of their resuscitations. Pediatrics nationally just doesn't see the volume of trauma that adult centers see. And so they were mainly just going over there to help as a resource. They were not going to be the primary nurse on these patients, but they did go and help with all the level 1 and 2 activations on the peds side. And that was 127 trauma activations that year. They did 87 MTPs on patients in the hospital, 696 rapid responses, and 215 code blues. So talk about budget and cost savings for a minute. A lot of places, the #1 reason people don't go this route, even if they want to, is because it's hard to determine how they're going to pay for these additional FTEs that are seen as an extra a lot of places. So a couple things just to hit on: trauma billing. So you can actually bill for lower level of trauma activations if you provide a resource above and beyond what the ED resource would be for a normal patient just coming in. And so those lower level trauma activations can be billed for by providing this resource. It also, if you're trying to have multiple educators or multiple PI coordinators or adding additional registrars, can help kind of fill the gap of all of those positions. They can help with outreach, which can increase your transfers and contribute more to your bottom line. Can help with relationship building with EMS, which can increase your transfers and scene calls and help with your bottom line. They can help with education, and many of these courses are actually revenue generating courses. So if you have enough people to increase your course numbers, that can help offset the cost of these FTEs. And then this wouldn't be as applicable here, but in other places, you could look at what contracts you have for additional FTEs. So if you have a person who comes in just to run Cell Saver, or a perfusion contract that's truly just running Cell Saver in your OR, something you could supplement. If you have additional staff in IR and in OR overnight just to set up rooms, something else that you could help supplement, or help with communications. Other ways that this actually fits with the budget and cost saving metrics is that you can look at the rounding. So if you have nurses rounding, they can be early intervention, kind of helping with those patients on the floor before they actually get really sick. It can help decrease the length of stay and decrease your complications. We also saw at Erlanger with running MTP that we decreased our blood wastage because we had one person who was responsible for the cooler. The resus nurse had to bring the cooler back when they were done with MTP, and we were able to decrease our blood wastage by about 8%, which in and of itself, if you look at the cost of blood in a lot of places, can pay for at least one of those FTEs. Also, you have a huge cost savings, especially right now with the nursing turnover, if you create a pathway so your nurses want to stay and want to grow within your system. And so you can actually save money just by creating the pathway for nursing retention. So in summary, a true leader has the confidence to stand alone, the courage to make tough decisions, the compassion to listen to the needs of others, and he does not set out to be a leader, but becomes one by the quality of his actions and integrity of his intent. Thank you. And I'm happy to take questions.
Well, Kayla, thank you very much. This is I mean, I would say maybe it's my own ignorance. It's just very eye-opening because I feel like this is something I didn't really appreciate all that goes on behind the scenes. And I appreciate hearing a lot about what the trauma program does, because I feel like this place sometimes is so big and we all feel like we are in our silos that it's, I guess, comforting and good to hear that it kind of, there is something that ties this all together. Does anyone have any comments, questions? I know we have some people from other places, and I'm kind of curious what other places may do.
You guys are quiet.
I would just say, sorry, it's Raj from Harborview, Seattle. We have had major issues credentialing people to run our Belmonts in the operating room, and we are just about to change over to a nursing-led model. We haven't got a clue how that's going to go, but I'm pretty hopeful that it's going to go quite well. How do other places run their Belmonts or their level ones in the operating room if they don't have a nurse running it?
So I've seen, and Dr. Knittel may have some other answers to this too. I've seen other places where anesthesia runs all of either the Belmont or level 1 in the OR. I've seen places where perfusion does that on trauma patients. I know in Tennessee, there are some places where you have your like anesthesia support staff who actually runs massive transfusion. The nurse model that I have seen done honestly works great because you have a nurse and an anesthesiologist kind of working in conjunction. Nurses can give blood as long as it is, protocolized really fast, while anesthesia can actually focus on giving meds and doing the pieces that they need to be working on. But I think it really just depends on how your setup is. But I know those are some of the ways that I've seen. Dr. Knittel, have you seen other ways?
I think all of us on the trauma team know that, we run the MTP pretty much exclusively. On rare occasion, I think we've been able to assign someone to it, but I think that's just part of our process. At least my process is, I assign someone whose job is to kind of watch the blood pressure and hang blood. I know there are other members of the team. I don't know if anyone else wants to weigh in, but I think that's been my impression, that everyone is doing something along those lines. We really, from anesthesia, run it in the OR. I'm not sure what they do in cardiac, if perfusion plays more of a role. And, I don't think we really put our ancillary staff in charge of it in the ORs. It's an intriguing idea, straight up, that it would probably be very helpful to have. I think it's the biggest thing is always having someone just kind of assigned to it, that's their job, is to focus on hanging the blood and adjusting as needed.
And I think the big thing there is the frequency. So if you have a nurse or an anesthesiologist, obviously depends on your facility. Here we do MTP a lot, and we have a trauma anesthesia residency. So of course, that's the bread and butter of what they do. But in other places, if you have other people running it that just aren't as familiar, that's where the issues tend to come from. So whether that's a nurse-led team, or if it's anesthesia, or it's an ICU nurse, whoever is doing it, I think the big thing is the frequency. So you want it to be a smaller group of people that do it most frequently to ensure you have the least amount of problems with it.
Yeah, I would say we do it enough that I think we all feel pretty comfortable in the OR. I think we see it enough in the ED that it seems to be assigned, and people seem to get it. I think where I see where this would be kind of really useful is getting the blood, because I know we debate that a lot of times. Is who's going to be the runner, and it's an extra discussion where having one person, like, okay, it's your job, you are going to give the blood, you're going to get it, and you're going to give it, and you're going to take it back, would simplify the process.
Agreed.
Obed, you have your hand up.
Yeah, I just wanted to say, Kayla, thank you very much for this very nice presentation. It brings a lot of stuff to mind. For example, your emphasis on clinical expertise in more than one area to be a good person in the ED. And I also found that interesting, that I haven't thought about it in over 10 years, but the FCCS, course for all staff. FCCS course is also very important to help bring everybody together. And I just wanted a moment to thank CNIDO for leading a diligent effort to form a division for trauma anesthesiology here at WashU. So congratulations, Justin. And I know you worked very hard at it and being for the lead for it. Thank you.
Thank you for that. Looking forward to a lot of work. Any other comments? Oh, but did you guys do anything at Shock Trauma along these lines?
So we had a perfusionist available at all times that ran our rapid infusion system, including our blood capture and reperfusion stuff. So we were very lucky that respect. I am not sure that is reproducible across the entire network. But I think Kayla hits up on a point which is very important, which is it is usually mandated somewhat by what your local resources allow you to, and you can function. So there's some of the stuff that Kayla presented and what you mentioned, and I think whoever mentioned from UW is similar. I think you have to sort of individualize it. But we had the luxury of having a perfusionist available 24/7, and I'm not sure most places can do that.
Yeah, I know we've had trouble with perfusionists here, so I think that would be difficult. Kayla, not to give away a lot of secrets, but are there things you're working on at WashU to kind of incorporate some of these aspects?
This is definitely an ask of mine. I would like to create a resus nurse team here. But I think the duties have to look different, right? It has to look different than what I've done in the past. Because the needs are different. And I think we have a huge opportunity, and we could improve a lot of processes by having a standard nurse who reports through the trauma program. But again, it would have to look different just based off of what we have. So
yeah, I had is why you were here.
What?
I had a feeling it was why you were here, is to work on some of these things. So I was just curious if there were certain aspects that you're really targeting that you think we could do a lot better on. I know we all probably could come up with one or two, but I'm really looking forward to seeing how this develops.
Thank you.
Any other comments, questions that people have? Well, I will get this posted on the YouTube channel. I'll send it over. And again, if you search for Trauma Anesthesia Society on the YouTube channel, we are starting to post these. You can go back and see a lot of our talks from the previous 3 years as we've been running this. And we've been getting more and more content up. So really appreciate that collaboration. Next month, we have another special talk. Tom Grissom from Shock Trauma is coming back to do his presentation on the top 10 papers that influenced trauma care for the past year. So he came last year and gave a great talk. I'm really happy for him to agree to do it again. You know, I think it's great to get that update. So I will send out that invite shortly. But yeah, thank you guys all for coming, and looking forward to seeing you next month. Thank you again, Kayla.
Of course. Thank you.